Alrighty, well, we'll go ahead and get started. I know we'll have a few more people joining us, but welcome everyone. Thank you for joining us today at the debut Canna Talk webinar of the Society of Cannabis Clinicians. We're thrilled to have everyone here and really thankful that you've all made time out of your busy days to be here with us. A few announcements before we get started. Please keep your microphone muted throughout the presentation. We will read aloud questions during the Q&A session at the end, so go ahead and type in questions in the chat at any time. We'll be keeping track of those. And we're glad to make this webinar open to SCC members and non-members alike. So if you're interested in joining as a member and want to learn more, please don't hesitate to reach out to me, Christine at cannabisclinicians.org. And likewise, if you feel like you're not fully utilizing your membership and would like to learn more about what resources we have available, I'd be happy to connect with you and set up a call. So without further ado, I will pass the mic to our host, starting with Dr. Patricia Frye.
Well, hello, welcome, and thank you everyone for joining us. I'm Patricia Frye. I'm author of the Medical Marijuana Guide, Cannabis and Your Health. And I'm also very proud to serve as chair of the SCC's Committee on Education. And we've just released a new clinical training curriculum that features the most up-to-date information from expert researchers and clinicians in cannabis medicine. So whether you're new to the medical cannabis field and interested in learning more about the basics of the endocannabinoid system and cannabis pharmacology, or you're looking for clinically relevant information in relation to specific medical conditions, it's all there. The curriculum is available as individual courses or part of a 5 and I believe a 12 module package. And we have right now about 14 courses that are available, and we will be releasing new offerings on an ongoing basis. So be sure to check out the course catalog on the SCC website and explore what's coming up next. We have a growing membership of clinicians from around the world, and members receive a discount on the courses, as well as a number of other educational benefits. So consider being part of this international SCC network. And so I'm super excited to introduce to you my very esteemed colleague and webinar co-host, Dr. Janester Wilson-King. She's a board certified obstetrician gynecologist with over 20 years of clinical experience providing compassionate and research-driven care to patients. And so after years of practicing as a full-service OBGYN, she founded Victory Rejuvenation Center, which is a private, holistic, and integrative wellness medicine practice. And that's where she provides some pretty life-transforming management modalities and customized medicines for patients. And she also serves on the Society of Cannabis Clinicians Board as vice president. She is a co-author of several research articles on the assessment of the impact of cannabis on female and male sexual function. And she's an expert on cannabis use in women's health. Dr. Wilson-King is a master in hormone therapy for both women and men. And today we're going to be talking about cannabis and women's health issues. And I don't know if you know, but March is endometriosis month. Who knew? And so we're going to ask Dr. Wilson-King if she can tell all of us exactly what is endometriosis.
Great question, Dr. Frye. Thank you so much for that wonderful introduction. At first, I started thinking, who's she really talking about? Wow. But at any rate, thank you so much. Endometriosis is when the endometrium, which is the inner lining of the uterus, gets displaced to other parts of the uterus or outside of the uterus and even into the abdominal cavity. And since this tissue responds to hormones, no matter where it's located, it's accompanied by a chronic inflammatory reaction. And that's what really causes the pain, because it's in areas where you're not supposed to have stimulated tissue. And about 10 to 15% of women of reproductive age have endometriosis. Some of the symptoms are dysmenorrhea, which is menstrual cramps, pelvic pain, pain with intercourse, and infertility. In fact, it is often during infertility evaluations that the diagnosis of endometriosis is made. And this endometriosis really does affect patients' social and economic participation. It affects their physical, mental, and psychological health. Many of the women are on antidepressants, anti-anxiety, and even antipsychotic meds. They often go through years of seeking help for their chronic pelvic pain without someone actually diagnosing what's going on. So they're placed on all these different meds. And oh yes, there's one more thing I don't want to forget. The families and partners and carers of those with endometriosis are significantly affected as well.
So once they figure out the diagnosis, how is it typically treated conventionally?
Conventionally, there's 4 different areas of treatment. The first is expectant. This is observation and symptomatic treatment only. This is only really something that's entertained if a woman is contemplating pregnancy or is nearing menopause. Those 2 conditions or hormonal phases in women alleviate the pain of endometriosis. So that's when that category of treatment is effective. The other category is medical therapy. Hormonal treatments will cause the shrinkage of the endometriotic implants. So this type of therapy is more suppressive rather than curative. Then there's surgery, and surgery can be conservative or definitive. It's conservative in that you have a laparoscopy and you can ablate the implants, or removal of pelvic organs. The final category of treatment is you can combine medical and surgical, preoperative or postoperative hormonal treatment with the surgery in between. The point I want to make here is that all of these modalities are mediocre and temporary at best.
Okay, so is there a role for cannabis in the treatment?
Absolutely, and I'm very glad you asked that. I was thinking, since we're talking about cannabis use, and I've seen cannabis medicine turn women with endometriosis lives around. Really, there's evidence that endometriosis is a clinical endocannabinoid deficiency condition, which is a theory proposed by Dr. Russo in 2001. And the clinical endocannabinoid deficiency theory is that in some cases, the body doesn't produce enough endocannabinoids or enough receptors for the endocannabinoid system to function properly. And this leads to an imbalance, because the ECS is for balance, and that thus the onset of disease. Clinically speaking, there's no one size fits all or one chemovar and dose that works for everyone. Even the same patient may need a different dose at different periods. You know, the female is actually built for cannabis. The female reproductive system has more cannabinoid receptors than any other area of the body except for the brain. So and estrogen and the endocannabinoid system have an intimate dance. One regulates the other. So there are many factors to the reason for the effectiveness of cannabis, involving one's endocannabinoid tone, the broader physiology, and one's psychology. Now, I've used THC dominant, CBD dominant, and one-to-one chemovars with success in many women. as far as the forms mostly use, their tinctures along with inhalation for acute or breakthrough pain. Certainly, though, as we all know who deal with cannabis, the method of administration is influenced by what the patient is comfortable doing, because we want them to do what they're comfortable doing and use their medication or medicate in the manner that is effective for them. The one other modality that's really effective are vaginal suppositories. I don't want to leave those out. They are very effective for the relief of chronic pelvic pain, pain with intercourse, and mood, stress, and anxiety. Suppositories in the vagina, and I know I'm talking like I'm lecturing to you, and I apologize for that, but suppositories in the vagina with THC do have systemic effects. And so you have,
Unlike rectal suppositories, unless they are THC hemisuccinate.
that's right, exactly.
So dysmenorrhea is pretty incapacitating. How do you tell the difference? How would a person tell whether this is dysmenorrhea, which is incapacitating menstrual cramps, versus endometriosis?
Okay, that's a good question, because a lot of people don't know that there is a distinction in the dysmenorrhea area. Cannabis has been used for dysmenorrhea for thousands of years. And there are mild forms and severe forms. There's two kinds of dysmenorrhea: primary dysmenorrhea and secondary dysmenorrhea. And endometriosis is the most common cause of secondary dysmenorrhea. Do you want me to go on and explain the difference between the two?
Well, that was the question.
Okay. This is fun.
Yeah. I'll put you on the spot.
Primary dysmenorrhea. I said one day we're going to have, as we can eat it to do this, we're going to each have a glass of wine while we're doing this.
Like
really exactly. Primary dysmenorrhea affects mostly adolescents, and it usually starts within a year of menarche, meaning that's when their periods begin. And it usually resolves with pregnancy, and it's clearly associated with menstrual flow. It's only during the time when you're bleeding. Secondary dysmenorrhea affects women between the ages of, say, 30 and 45, typically. And the pain can occur at any time. It's not just during menstrual flow. And the pain from endometriosis is usually much more severe and certainly quite debilitating.
Okay. So, and obviously there's a role for cannabis in treating dysmenorrhea, but maybe not with the same hormonal implications as with endometriosis. Interesting.
Correct.
Interesting. Okay,
Yeah.
so I did a spiel advertising the webinar, telling people to come on in and learn everything they can about cannabis and sex. So let's start off with why does sexual activity change with aging?
Sexual activity for a woman can change at the drop of a hat. So it's not just with aging, but we're going to talk about with aging now. Of course, the most obvious reason is because your hormone levels change. They decline in the perimenopausal and postmenopausal stage. And one of the results of declining hormone levels is you have less and less desire for sex. Sometimes you don't even think about it. There's also thinning and loss of moisture in the vagina. There's pain with intercourse and declining or lessening satisfaction or enjoyment with sex. It gets harder to have an orgasm as your hormone levels decline. There are other reasons, including medications. Antidepressants are passed out like candy, and they are known to cause sexual dysfunction, particularly in women. Although Wellbutrin probably is one of the ones that seems to have less impact. Then there's anticonvulsants, birth control pills. Birth control pills can lower testosterone levels, and the testosterone levels will definitely decrease your desire for sex. Then you have antipsychotics and other medications. And then there's surgery. When you have surgery on some of the reproductive organs, that can cause a change in your desire for sex, and depression or anxiety. And the biggest factor for women, relationship issues. Just the fact that maybe we've been together too long, or there's no foreplay. And you know, men, foreplay can start really earlier in the day so that maybe there's a reward later on that evening.
Like vacuuming the living room?
Yes, or cleaning up the kitchen after dinner. Say, oh, honey, why don't you just go upstairs and take a bath and relax? I'll clean up the kitchen. That's the greatest start of foreplay. And
the foreplay starts with you standing up in about 3, like in the middle of the afternoon, right?
Exactly. Start it early and avoid the rush.
But imagine that arthritic pain might come into play too. If you have like stiff hips and poor flexibility, that might kind of
affect your mobility. Absolutely. Absolutely. But I don't know if cannabis is going to help the relationship issues, but it might. It might help. Look at your husband or your partner more lovingly, because you feel better and you're in a better mood.
The things that get on your nerves don't get on your nerves as much.
Right, that's right.
Yeah. But I did read familiarity and sexual attraction were inversely proportional, that the longer you're with somebody,
That's exactly right. It's like, oh, you again? But you know, do something a little different, and then it won't be an again.
All right, so we talked about anxiety, and of course, you know, cannabis is a great anxiolytic. And what about dyspareunia, painful sex from other causes? Like, what other things besides endometriosis would cause that?
You know, before I get to that, because you did ask me about how cannabis helps with sex, or do you want to do that after the dyspareunia?
Well, I was just okay. Yeah, let's talk about all the things that you just talked about. How can cannabis help those?
Okay.
Okay.
I'm so glad you asked that. I'll tell you, what I've seen in clinical practice, my clinical practice at least, is that cannabis use seems to really increase the desire for sex. It increases sexual satisfaction, increases the sensitivity to touch, and actually it also can increase the intensity of orgasms. So if you're a woman whose hormone levels decline, and it's very difficult to have an orgasm, or certainly have an effective orgasm, cannabis can really help with that. And cannabis also seems to help my patients relax more during sex and help them to be more present, instead of us usually, you know, looking at our watches or thinking about what we need to do when this is over. We can actually be more present and pay more attention to what's going on. Also, you know, THC can alter the perception of time so that you can prolong the feelings of pleasure. And there's one other interesting point here, is that oxytocin, which is a hormone secreted by the pituitary gland, the posterior pituitary gland, that's responsible for a number of reproductive functions such as breastfeeding, but also is responsible for bonding and hugging. It's sometimes called the hugging hormone, but the release of oxytocin is released, it appears to have a role in erection and orgasm. And getting back to the endocannabinoid system, the oxytocin stimulates the release of anandamide, and anandamide levels can also be increased by CBD. Also, estrogen can regulate the Frye enzyme that breaks down anandamide, and MAGL that breaks down 2-AG. So you got a lot of things going on in combination that can really help with sex. And I have finally to say, I have a favorite saying: a hormonally balanced postmenopausal woman who uses cannabis is a brand new woman.
All right. Sign me up. Okay. So, all right. So shall we now talk about painful sex, or do you think that you've covered that sufficiently?
Well, there's one aspect I didn't cover that's important,
Mhm.
and that's when pain is because of pelvic tightness or muscle spasms. Cannabis is really, really good with that, because if a woman experiences severe muscle spasms and pain with sex, maybe after the fourth or fifth time, then the thought of sex can stimulate those muscle spasms. So cannabis really helps with that. Besides the thought of it stimulating muscle spasms, the thought of it causes anxiety, and cannabis can help the patient. Well, certainly is anti-anxiety, and is very effective in helping the patient to relax, like I already said. And that's where vaginal suppositories really play a huge role.
Yeah, I've had a couple of patients with dyspareunia from pelvic floor dysfunction, and they've had really good response to cannabis, and very appreciative that they can have sex without pain.
Oh,
So
yeah.
we touched on vaginal dryness. I want to ask you, what is your opinion on cannabis-based lubricants versus conventional KY jelly?
Sure. I don't want to sound like I'm raining on someone's parade, but
All right, I think I know what the answer is then.
right. Cannabis lubricants, which, well, they're mostly oil-based, and that's because cannabinoids are lipophilic.
Mhm.
But use of an oil-based lubricant over a prolonged period of time can cause vaginal dryness, because depending on the oil, of course, the oil can block the glands in the vagina to prevent moisturization. So you have to be careful with that. You want something that's more water-based, which is really hard to do with cannabis products. So we have to find, I know some people use some of these cannabinoid lubricants on the market and do have good results initially, but after a period of time, it seems to not be as effective, and that's why.
Oh, that makes me think that maybe some sort of nano emulsified, water soluble product might be a better base for the lubricants, for the personal lubricants. Yeah,
Now you're giving away our idea.
okay. All right. I have no way to make it, but okay.
Yeah,
All right. Let's talk a little bit about what are your tips on using cannabis, because cannabis there can be some problems sometimes, depending on what you use and how much you use and how you use it. So what are your thoughts?
mainly if you're going to use cannabis before sex, inhalation is the best way. It's the faster acting, and it seems to really do the trick, and it lasts an appropriate amount of time. But I'll tell you this: if you use an edible and don't ingest it far enough in advance, you're going to have a good night's sleep and have sex in the morning.
That should be the name of a new drink, like sex in the morning instead of sex on the beach.
But yeah, that is. So you have to be careful with what you use if you're going to use it just before sex. You need something that's really going to have an onset of effect, so it really will help you have sex at that time.
And I would imagine too, even using inhalation and kind of the whole sharing of the joint, the puff puff pass might be part of the foreplay and the intimacy. Yeah, and heaven help you if you take it too much of an edible and you're like, in paranoia mode.
That's true, because that reminds me of I've had some patients tell me they fell asleep before they could have sex. Some actually experience an increase in anxiety, and that's because the dose is a little bit too much. And some patients that I have don't have any effect one way or the other with cannabis, and that's okay because it's all individual, and you know, doesn't mean that maybe in a year or two it may not affect that, and maybe there's some change with time, and doing some different things in your lifestyle may help. But the one thing I do want to say is that in both sexes are male and female, that is, cannabis is dose sensitive, meaning a high dose may not produce the desired effects. It may actually have adverse effects, particularly with men. Men are much more sensitive to the doses of cannabis than women. And high doses of THC primarily can cause erectile dysfunction. So you do have to be careful.
Yeah, I also read that too much THC can impede ejaculation, which I guess could be a benefit for some and a curse for others, depending on the situation.
Right, exactly.
All right. Okay, so now that everybody has used a little cannabis, they're all relaxed, they're well lubricated, they're enjoying sex, having good orgasms. Let's move into pregnancy. Let's say
eventually that's going to happen.
Well, not for us old folks, but for the younger ones.
That's right. Well, pregnancy and cannabis is the best things for pregnant women to ingest are healthy, real whole foods, drink clean water, and breathe fresh air. Do not ingest or smoke drugs of any kind, including tobacco, alcohol, caffeine, cannabis, pharmaceuticals, opiates, and methamphetamines while pregnant. And that I make that statement because I don't want anybody to think I'm saying it's okay to use cannabis during pregnancy. I would rather you not, for sure.
Okay. And any comments on some of the studies looking at, particularly, I always have questions about the Jamaican study, and people ask me about that often when looking at, or when not making, and I'm boarded in pediatrics, so I'm there to get after the baby is in trouble. So what about the Jamaican study? What are your thoughts on that?
Melanie Dreyer, Dr. Dreyer, excuse me, did a fantastic job with that. I do want to say there's one thing though about cannabis and pregnancy. There are instances in which a pregnant patient is going to come to you if you're an obstetrician, gynecologist, and they're pregnant and they're using, say, for example, CBD to control their seizures, and that's the only thing that controls their seizures. So you have to, that's why you have to really know the studies and know how to help a woman who is using cannabis and or CBD during pregnancy. There are some things you should know. But the Melanie Dreyer study, published in 1994, is a really study. It's an old and very small study, but probably the only pure cannabis use in pregnancy study. It was actually a prospective study, which a lot of studies in using cannabis in pregnancy are not. They're all retrospective and are based on recall, and recall is not always reliable, for sure. So in her study, the study was in rural Jamaica, and there were Rastafarians and rural Jamaicans, and they used cannabis probably like we take aspirin or Tylenol. They used cannabis for everything, including spiritual and ritual purposes. Some women smoked, but most most drank cannabis tea. And cannabis was also used as a relaxant for labor. And she had 24 patients who were using prenatal cannabis and 20 non-exposed. And they found no significant differences between the exposed and the non-exposed at birth, 3 days after birth, and then at 1 month. The exposed newborns actually showed better physiology, such that they had better scores on the testing that was done. She also did a 5-year follow-up that found no significant difference in the developmental testing outcomes. Now, Dr. Dreyer did stipulate that these findings could be, the 5-year follow-up, could be more correlated with certain aspects of the home environment and the regularity of preschool attendance as opposed to cannabis. So, but that was
wasn't that group, it was a little unusual for women to be smoking, that, like you said, it was more typically used as a tea for most women.
Exactly, yes, most women use tea, but there were a group of smokers, and they were usually of higher socioeconomic status and higher education women, and they, as we women do, look, we can do that as well as men can do that, so we're going to smoke. And that's what they did. I think that's, woman power.
Yeah, I would imagine too that that it may be difficult to put everything on that study, given how long ago it was done, and that the THC content of the cannabis was probably a lot lower than what's available now. I don't know. Yeah, I would imagine in the 70s it was like 7%, 6-7% THC.
Right, but one of the things I say to that is, number one, our testing capabilities were not as good as they are now. Also, cannabis sat on the shelf a lot longer before it was tested back then. And you know what? Even if it was lower percentage, you smoked what you needed for the effects you wanted. So if you had to smoke 2 or 3 joints to get the effect, and as opposed to nowadays smoking 1 will give you the effect, you're still smoking really similar amounts. And I do know, I've heard a lot of growers talk about, no, it's not that much different. It might be because, like I said, the testing is better today, and cannabis is tested right away. It doesn't sit on the shelf. That's the only way we tested cannabis back then, is when it was confiscated and sat on the shelf until somebody said, look, I want to look.
Okay. So you're thinking that maybe the THC content was actually higher, but due to breaking down the CBN, that it just showed to be less. I got you.
That's one. That's, it's a possibility. I'm not saying that this is totally wrong. I'm just saying there's certain ways that we can look at things.
Okay. Yeah. And then just a quick question, just to go back a little bit about some of the instances where someone who is pregnant may benefit from cannabis, where the benefit from the cannabis may outweigh the risk. Might be something like hyperemesis, where nothing else is working, and this may keep the patient out of the hospital, and so that she can stay home with, maybe if she has other children, and she's feeling better. So I would imagine that there are some instances where like in pediatrics, it's always about benefit versus risk, and if the benefit outweighs the risk, then we go with the benefit.
Absolutely. I had a patient come to me who had severe hyperemesis with her first pregnancy, such that she was in the hospital most of the pregnancy, on IVs, and it was just horrible. And when she became pregnant again 5 years later, she was just deathly afraid of that happening again, and came to me for a consult. And we talked about things she could do. There's a lot of non-cannabis things, but the patient at this point was so stressed. And stress is a factor too in pregnancy, and can cause pregnancy loss, poor fetal growth, and things like that. So what this patient ended up doing is puffing on taking a drag of a joint or cannabis two or three times a week helped her keep her food down and prevented hyperemesis. And she only did that the first, maybe during a month in the first trimester, and then she was fine after that.
So that's usually when it happens, right?
Correct.
By the end of the first trimester, things settle down.
Yes, it's a very debilitating condition too.
Any thoughts about breastfeeding and using cannabis?
You know, cannabinoids are present in breast milk. And in fact, I'm going to highlight this because I think I saw her name, Michelle Sexton did a study on cannabis in babies who were being breastfed. And the effects on the baby are difficult to determine because oftentimes if the woman is using cannabis during breastfeeding, she probably used it during pregnancy. Probably, not definitely, but probably. So it's just hard to tell what affects what. Certainly the acute effects are related to the breastfeeding at that point. But I'll tell you, many of the policy statements from American College of OBGYN, American Academy of Pediatrics, and the Academy of Breastfeeding Medicine, to name a few, do not state that the use of cannabis is a contraindication to breastfeeding, but rather breastfeeding is encouraged while the use of cannabis is discouraged. Mm-hmm. So what they're saying, and this was also reported in a study by Dr. Marcoux and Hill and Reed, 2012 and 2013, that the benefits of breast milk outweigh the perceived dangers of cannabis. Now, I'm not saying that to encourage women to use cannabis while breastfeeding. Certainly, we want to counsel them and help them to find other methods while they're breastfeeding, other methods to relieve whatever symptoms they're trying to relieve while breastfeeding.
Okay. Great. So tell us, what are you going to be covering in the women's health modules?
Well, we talk about the history of cannabis use, also how the endocannabinoid system interacts with the female genital tract and early fetal development. A lot of the module is a review of the literature because, we see these studies coming out at various times. What do they say? What do they mean? And we talk about the many facets of cannabis use in pregnancy, including the effects on the mom, the effects on fetal growth, the effects on, does using cannabis during pregnancy increase admissions into the neonatal intensive care unit, neurodevelopment outcomes. The 2020 study that I didn't talk about is covered in this module. That study demonstrated that the primary association between maternal cannabis use and autism spectrum disorder risk increases by 50%. So that's something we touch on too. Yeah. And then we look at why is it so difficult to study cannabis use in pregnancy. Mm-hmm. And the reasons a woman would use cannabis in pregnancy. There's also a section on CBD use in pregnancy. Mm-hmm. We do talk about cannabis and breastfeeding. And then finally, it ends with best practices guidelines. Something that's kind of like a handout or something you can use to help you in managing patients who want to use cannabis or have to use cannabis during pregnancy.
Excellent. Fascinating. Well, thank you so much for all this information. And let's see if Christine has some questions for us from the audience.
Okay, thank you. And let me say this to everybody. Look, what I say is certainly isn't the bottom line and the rule. There are variations on a theme. And yes, there are some people that can use cannabis do use cannabis while breastfeeding and do use cannabis while pregnant. And we just, as healthcare providers, need to not shy away from that and treat people without judgment and let the women know, okay, I'm here to help you. and not judge you. And what we need to do in this country in particular is to stop criminalizing pregnant women for
Yeah.
using cannabis and causing disruption of their families and things like that. That's just so unnecessary. It's so detrimental and it's just wrong, just wrong. So I wanted to say that too.
Thank you.
Sure.
All right, Christine, we're going to pass the baton.
Thank you so much, Dr. Wilson King and Dr. Pfeiffer, for leading that. That was so insightful, and wow, you answered so many questions already that we've all had and been curious about on this subject. So thank you. And we do have a list of questions here. I'll invite our new marketing and public relations director, Genesis Emery, to come on and ask these. We're so excited to have her on board. And so you'll all get to meet her as well. Welcome, Genesis.
Hey, everybody.
Hey, Genesis.
Hi. So, okay, a few of the questions that we had. The first question is from Dr. Felicia Dawson. And she says, thank you, Patricia and Dr. Genester, for all of your work behind the scenes and for sharing on this program. Would you elaborate on suppositories as a route of administration, vaginal versus rectal? Some have said THC is not picked up on blood tests when delivered this way. I find that hard to believe, as if it has access to blood vessels.
Yes, Felicia. Dr. Dawson, excuse me, or Dr. Felicia. Good question. And, you know, the vagina is highly absorbent. And when you use vaginal, when you put the suppositories in the vagina, it does get absorbed. You do have systemic effects. You do have psychoactivity, and you can have impairment. It's just a matter of establishing the dose, start low and go slow, of course. And yes, that's true. That's different than using a rectal suppository, as Dr. Patricia mentioned earlier. You need the THC hemisuccinate in order for rectal THC to be absorbed. So that's a big difference between the suppository in the vagina versus the suppository in the rectum. That vagina, you're just not going to get anything past it to that. It's going to absorb whatever is put inside, believe me.
Yeah, and I think it's been a misconception when people have needed large doses of THC, let's say if they're trying to treat a treatment-resistant cancer, where they're using rectal suppositories because they're under the impression that they're absorbing the THC, but without the impairing effect. Well, if you're not impaired from 200-300 milligrams of THC, it's not in your system.
Exactly, exactly. And you know, getting back to the vagina being so absorbent, that's a method, it's a route of administration I use for some of my hormone patients, vaginal troches, and you put the hormones, and you can use really low doses like 0.10 or 0.20 milligrams in the vagina and get a lot of systemic absorption and good hormone levels. So the vagina is highly absorbent. It absorbs 99% of what you put in it, generally speaking.
Awesome. And so our next question here, it doesn't have a name behind it, but the second question is, if THC has been shown not to be absorbed rectally, what is the difference about vaginal tissue, and why would cannabinoids be absorbed here?
I think we just kind of addressed that.
Just went through that. So yeah, like I said, the vagina is very, very absorbent, and the cannabinoids absorb very nicely through the vagina.
And our next question is, let's see, along these lines, what is the best route to administer cannabis to ease pain in intercourse? Cannabis vaginal suppositories, cannabis lube, inhaled, tinctures, or all of the above?
Certainly any of the above are helpful, but I find the most helpful are the vaginal suppositories. They really are quite effective, especially if the pain is such that it prevents sleep. Cannabis will help you sleep, plus relieve the pain so you can sleep even better. And it's an all-around effective mode of delivery of the cannabinoids.
I would think that the suppositories, and with my patients with dyspareunia, with pelvic floor dysfunction, they find that the suppositories are superior to other modes of delivery, but it's about, what the patient is comfortable with.
Absolutely. Absolutely.
Perfect. And then our next question is let's see here. Please address the use of cannabis as a treatment for various vaginitis problems, such as BV, candida, and then also several of my patients have used it successfully with lichen sclerosis. Have you seen positive effects?
Oh, sure. Lichen sclerosis. Yeah, that's a pretty common vulvar problem. And yes, topical cannabis in that area is wonderful. Really works well. You just have to make sure the topical is okay for mucous membranes. You don't want a topical that's effective for that's only should only be applied to the skin. You want it to be absorbed by the vulva, but it is helpful. I've had actually 2 patients who've used that to treat their lichen sclerosis over time. So it works really well. What was the other part of the question?
About candida and EBV.
Candidiasis is a yeast infection, and certainly using an antifungal that's supportive of that is effective. I mean, we try to, I want to say this gently, we cannabis lovers try to use cannabis for everything and think it's a panacea. But sometimes if I have an infection, a bacterial infection, give me an antibiotic. I'm not going to use cannabis for that. So, if you want to use cannabis and the antibiotic, but you want what is really effective. And I would, like for bacterial vaginosis, you need an antibiotic to really cure it. So there's a place for some pharmaceuticals, and I'm not afraid to use them or even write a prescription for them. But cannabis can be used in a lot of areas, but it's not the only available treatment method, excuse me.
And I think that, we know that cannabinoids and different terpenes have antibacterial, antifungal, antiviral activity. But as physicians, I think that we have to rely on things where we have a little bit more evidence that something's going to be effective. And I could see using cannabis for maybe some discomfort, but I don't know that I would rely on it to treat an infection.
Certainly. And if you don't adequately treat a simple yeast infection, you can really be in for a lot of vaginal discomfort and really to the point where I've seen candida vaginal infections just really look like something totally different. It's just because the candida is so severe and has been there so long untreated that it's very, very detrimental to the vaginal mucous membranes, the vulva. It causes lots of inflammation. So you want something that's effective and going to treat it immediately.
Yeah, and there are a lot of things that are effective. I know I read that that men who don't have access to anti-fungal foot powder and spray, like when in prison, that they pee on their toes, they pee on their feet because there's something in the urine that's anti-fungal and it's quite effective, but I don't ever make that recommendation.
Could it be the acidic, the pH treating?
If it's the urea, I mean, the urea in urine gives you great skin. Those babies' bottoms is all from the urea. But I don't know if I.
Whatever it is, I'm not feeling it.
Back in the 80s, they started talking about putting the wet diaper on your face and you would have like this fantastic complexion. Mm-mm.
No, I'm not feeling that at all.
Okay,
Some people
next
can do
question.
it, and I'm not judging. I'm not judging.
No, right, no judgment.
No, no judgment here.
Okay.
But hey, if that's what you want to do, go for it. Go for it.
All right, anything else?
Anything else?
Yes. So our next question is, why do women crave chocolate around their periods? And does it have anything to do with the ECS?
You know, I think it's a combination. As I said, hormones fluctuate, and estradiol in particular uh, will fluctuate. And if you have an imbalance of maybe a little more estrogen than progesterone, there is a ratio of estrogen to progesterone that is there's a range, and that ratio is kind of the normal part of physiology, but because of our lifestyle and other factors, estrogen levels can go higher than progesterone. So then you'll end up having an estrogen dominant type picture. And estrogen is what stimulates the craving for various foods. In many of my presentations, when I talk about hormones, I'll talk about estrogen dominance, and that's one of the hallmarks symptoms of estrogen dominance is craving for salty, crunchy chocolate. Also, chocolate is stimulating. So if one of the things of estrogen dominance is fatigue, and it could be partly your body trying to give you something to help put a little pep in your step, and so it'll crave chocolate to give you that little caffeine boost, and it can be helpful that way. So it's a combination of hormones and the endocannabinoid system for sure, especially since they're both so intimately involved.
Awesome. And then our next question is, do you have any experience with the O shot, PRP, and how could that help with ECS in the reproductive area as far as resurfacing, circulation, collagen, etc.?
Oh, wow. You know, I don't have much experience in that. So that question is a little difficult to answer. But I'll tell you this, the next time that question is asked, I'll have an answer for you. I'm not going to try and snow you over and try to BS you and find some reasons I don't know.
Okay.
All right, I think we're about out of time. We're coming up on the hour. Do we have time for just one more question, and we're going to give it back to Christine?
Yes. Let's see here. All right. Can cannabis use through pregnancy help in high-risk mental health patients?
Oh my.
Depends on the mental health condition.
Depends on the mental health condition. And, you know, yes, there are situations in which women will and can use cannabis during pregnancy. I really don't, I want to be careful here because I don't want you to think it's okay all the time. And the literature is such that it's so inconclusive, but there are some things that have made it a little bit more compelling to really try and be careful about that. So I don't want anybody to feel like, go ahead and do it, no big deal. But I also don't want anyone to suffer because they can't do it, or you know, other things are stressful in a pregnancy as well. And if you have, like I mentioned earlier, seizures, you don't want to have seizures throughout your pregnancy because you and the baby could die. So, you know, we got to weigh it, and it's really dependent on the physician and patient discussing and the benefits far outweighing the risks at that moment. So we do need to just be careful with that. And I saw Laura Bourgeau was here, and I wanted to say hello to her, but I think she's gone now.
I wanted to point out about.
I'm here and
Oh, go ahead.
Oh, there you are. Okay. Thank you so much for being here. And I've been wanting to reach out to you and talk to you. So we should talk sometime.
I have loved the presentation. I'm just putting that in, and it's a lot of love coming from.
Oh, thank you.
Thank you.
I've seen a lot of her work. She's in Colorado, correct? Yes, and has done a lot of work in pregnancy and cannabis use, and really is pretty outspoken. So I wanted to say hello to her. Sorry.
I just wanted to make a comment about the mental health issue, especially high-risk mental health patients. I think we can get into trouble with cannabis at times with these patients. There's something to be said for using cannabis to treat things like anxiety and maybe some depression or dysthymia, PTSD. But when we're getting into psychotic conditions where patients are best stabilized with pharmaceuticals, I think that the decisions about cannabis, is particularly THC, which can precipitate psychotic events, they should be left to the mental health providers. So I would say tread cautiously when dealing with patients that are at high risk for significant neuropsychiatric illnesses. That's all I'm going to say.
Okay.
Okay.
Do we have time for just one more question?
It's 1 o'clock.
Yeah, it's 1 o'clock, and I do have a patient in about 15 minutes.
Okay.
I mean, if this is something burning and we need, it's going to be disastrous if we don't answer it. We can consider it, certainly.
What's the question, Genesis?
It's the last one. How about cannabis in pregnant women who use cannabis to control chronic neuropathic pain symptoms?
Okay, well, I think we really touched on that. And that's just something you have to discuss with your physician and work it out. Yeah, yes, there are risks, and they may be minimal, they may not be. We just don't know. So if we can find alternatives, non-cannabis alternatives, we should do that. And if you can't, we're going to counsel you through it. We're going to help you no matter how much it takes to help you. We will help you. We will be your healthcare provider. So work it out with your physician and go from there.
I think with any condition, if the benefit outweighs the risk,
Sure.
if that's the only thing that keeps a patient from being in pain or from suffering, then you have to use your judgment.
Yeah, it's an individual approach, and between the patient and the physician, and they'll make those appropriate choices depending on the patient's history and the patient's need and medical condition and things like that. Because as I said earlier, the, stress is a huge cause of adverse pregnancy effects and outcomes. So we don't want to disregard that. So sometimes the benefits do far outweigh the risks.
Thank you both so much for sharing your time and wisdom with us. Thank you everyone for attending the kickoff webinar for Canna Talk. This will be a monthly series every fourth Thursday of the month. So all meetings will be recorded and available to SCC members. So if you missed it today, you can always rewatch it if you came at the end. We also have some upcoming talks. So the next one will be in April with Dr. Stacy Kerr, who authored our Movement and Neurological Disorders in honor of World Parkinson's Day that is in April. And then in May, we have Dr. Zachary Walsh, we have Dr. Ethan Russo and Bonnie Goldstein coming up later in the summer. So stay tuned. We'll be sending you announcements, and we look forward to having these clinical conversations with you all.
Yeah.
Thank you so much to our hosts, Dr. Frye and Dr. Wilson King.
Thank you all. Thank you all for coming. Can I ask that the team stay for a few minutes, just a few minutes after? Okay.